my talk's on cervical spine trauma, which was a pretty good learning opportunity for me, having not done a spine job through my unaccredited time. So it's quite a broad topic, clearly, and as such I've tried to pick a few subheadings to cover as much content as possible, but without talking for too long and everyone going to sleep. So I'm going to start with just some brief anatomy, looking at the criteria for imaging, assessment and evaluation of the patient, atlantoaxial injuries and subaxial injuries. So the anatomy cover the craniocervical joint, atlantoaxial joint, and the bony and ligamentous anatomy of the cervical spine, cervical spine. So this is a sagittal view of the occipital-cervical articulation. The occiput C1 joint's a shallow condyloid joint that provides some osseous stability. The dens extends cranially from the axis, C2, to form a synovial articulation with the posterior aspect of the anterior atlas, which I've got an axial shot of that in the next slide. Laterally, C1 and C2 have osseous articulations. There's intrinsic ligaments that provide most of the stability for the occipital cervical articulation. So this slide shows on the left the posterior and on the right the anterior views of the atlantoaxial articulation, the atlas referring to C1 and the axis referring to C2. And this joint provides the majority of rotational range of motion in the C-spine. You can see the dens of C2's articulation with the posterior aspect of the anterior atlas, as I mentioned in the last slide, and the transverse ligament that sits posterior, the dens, sort of supports that as a sling and helps with the rotation. So the main ligaments there marked AP is the apical ligament, which goes from the dens to the anterior portion of the foramen magnum superiorly, the transverse ligament, and AL, the alar ligament that goes from the occipital condyles to the lateral dens that supplies that support as well. So looking at subaxial anatomy, so more sort of C3 through to C7, just quickly run through it because it helps to understand the fracture patterns I'm going to talk about a little bit later on. So the vertebral body has two pedicles leaving posteriorly that then join to the two lamina and completing the ring of the spinal canal. The lamina connect posteriorly and form the spinous process. And the transverse processes bilaterally help to form the transverse foramen, which is unique to the C-spine and houses the vertebral artery and vein, which is clinically relevant. You note the superior articular facet in the diagram because this is important when discussing facet subluxation dislocations. Spinal vertebrae are separated by intervertebral discs made up of the nucleus pulposus and annulus fibrosus, which is again relevant to the injury patterns I'm going to talk about with disc herniation. So the sagittal spinous anatomy, so the anterior and posterior longitudinal ligament running the length of the spine, providing support to the vertebral bodies and discs. The ligamentum flavum, which connects the lamina of the adjacent vertebrae, and the interspinous ligament, which connects the spinous processes. The nuchal ligament, the yellow there posteriorly, is unique to the C-spine. It attaches the spinous processes of C1 to C7, and it's also an attachment point for trapezius and the rhomboids in the muscular anatomy. The final piece of anatomy, which is relevant sort of more clinically, is the spinal columns, which was initially sort of developed for thoracic and lumbar spine injuries, but is also used in clinical practice in terms of describing the lower C-spine injuries. So the anterior column is including the anterior longitudinal ligament, the anterior 2/3 of the ventral body, and the anterior 2/3 of the intervertebral disc in blue. The middle column is the posterior 1/3 of the vertebral body, posterior 1/3 of the intervertebral disc, and the posterior longitudinal ligament in green. And the posterior column is everything posterior to this in yellow, including the posterior longitudinal ligament, the pedicles and facet joints. So more practically and hopefully helpful for some of the residents and registrars is the evaluation of the patient. Any C-spine patient or suspected C-spine injury needs to be treated with a trauma approach, and a lot of people have done the EMST course, emergency management of severe trauma. And so approaching these sorts of patients with an APCD type approach and immobilizing the spine adequately in a collar or sandbags, depending on what the protocol of the hospital is. It's important to do a primary and secondary survey as part of that, because as we'll come on to with the criteria, any distracting injuries or other injuries are very relevant in your C-spine examination management. So the history, the mechanisms, particularly important, working out what types of injuries could have been caused, the pain, location of pain, where the pain is, and radiation of the pain, sensation or motor deficits that have been noted by the patient, including whether they ambulated as well after the injury, and bowel or bladder dysfunction. So on examination, clearly you're going to undertake your primary and secondary survey, but specifically for the C-spine, looking for palpation of tenderness, any obvious step-off, crepitus, if appropriate, range of motion, and I'll go through this Canadian C-spine rules, which discusses range of motion and when that's appropriate, and then a neurological examination. And probably the most common sheet that we've seen is the ASIA classification. I won't go through all of that, but relevant to know in terms of neurological examination. So if you're, the resident or registrar down in the emergency department and you're wondering whether you should be imaging these patients with suspected C-spine injuries, we often use the Canadian C-spine rules or NEXUS criteria, the helpful criteria in deciding on the inclusion, exclusion, and then whether you should be imaging them. So the Canadian C-spine rules specifically had a prospective study in 1996 to 1999 and was published in 2001 in the American Academy Journal. It was a sample of almost 9,000 patients who presented with blunt trauma, so in a big study, who was stable with GCS of 15. And the rules identified 100% of C-spine injuries present in the cohort. So the inclusion criteria, because of the nature of the study, was anyone's over 16, acute trauma to the head and neck, they needed to be stable with a GCS of 15. The exclusion criteria were trivial mechanisms, penetrating trauma, so the incorrect mechanism, presenting with acute paralysis clearly, or other known vertebral disease such as ankylosing spondylitis, which creates a larger lever arm on the C-spine. So these are the actual rules. So any high risk factors, so over the age of 65, or dangerous mechanisms like a fall from over a metre or a motor vehicle accident of over 100 k's an hour, should score basic C-spine imaging. So if you don't fall into that category, we drop down for any lower risks. So a simple rear end MVA, it was ambulatory at the time, delayed onset of neck pain. Then you can move to, according to the C-spine rules anyway, actively rotating the neck and assessing for pain and range of motion. If you get through all of this and there's no issues, then you can avoid doing any imaging. But you can see there's a pretty low threshold for C-spine imaging. The NEXUS criteria, which potentially is slightly more widely used, was published in 2013 in the New England Journal of Medicine. It was based on 800 rather than 8,000 patients, and all but 8 were identified that went through who had C-spine injuries. So 8 people were missed. 2 of these were clinically significant injuries and only 1 required surgery. So they've said they have a sensitivity of 99% off that data. So the NEXUS criteria again helps us to decide whether we need to image the C-spine, with the exclusion criteria being tenderness in the midline of the cervical spine, any altered mental status, so that's similar to the C-spine, Canadian C-spine rules, focal neurological deficit, evidence of intoxication or not being able to be compliant, and a painful distracting injury, which in orthopedics and undertaking primary and secondary surveys is particularly relevant. So once you've moved through your history and examination, decided to image the patient, initially you would commence with a lateral of the C-spine. Obviously that's an MRI, but a lateral x-ray of the C-spine, including also an open mouth odontoid view, should be taken from the anterior side as well. The lateral x-ray, it's really important to include C7 and T1, and often they're not imaged adequately and you do need to repeat that. If you then have further concerns, you can proceed to CT scan, which is good for your bony evaluation, and 3D reconstructions if you are planning surgical intervention. And MRI is really the gold standard for assessing the cord, the disc, and any ligamentous injury. So looking at a normal X-ray, if you're in the emergency department as a junior doctor, you're looking at the congruity of the lines on the lateral X-ray, the anterior vertebral line, the posterior vertebral line, and the spinolaminar line there as APS. And it's important to look for translation subluxation through those lines. Also looking again at the normal X-ray, the circle being the facet, the triangle being the lateral mass, the square being the laminar, and the diamond being the spinous process, are the points to look for fracture sites or indications of injury in the lateral C-spine X-ray. So I'll move on to some of the specific injuries that we see. Some of them aren't particularly common, but they are interesting fracture patterns or injury patterns, so I thought I'd include them. So the atlas fracture is a hyperextension, lateral compression, axial compression are the common mechanisms. There's three types, which you can see in the diagram here: posterior arch, isolated lateral mass fracture, and what's known as a Jefferson fracture. So the posterior arch fracture is caused by axial compression with hyperextension. It's a stable injury and can be managed with a collar. The isolated lateral mass fractures are caused by asymmetrical axial compression, and the Jefferson fracture or the burst fracture of the atlas is classically a 4-part fracture, which you can see in the red in the picture there, but has been described as 2- and 3-part fractures. It's important to have an MRI scan with the Jefferson fracture because an intact transverse ligament, which you can see in the green and I referred to in the anatomy part at the start with that sling behind the dens, if that's intact, this can be managed conservatively. So it's important to have an MRI scan if you see this fracture pattern. Dens fracture specifically is an odontoid tip or C2 vertebral body fracture. Patterns to look out for with presentation in the emergency department is young high energy trauma or elderly with even just standing falls. So the classification system for this is the Anderson-D'Alonzo classification. It's a type 1, which you can see in the diagrams, an oblique fracture through the odontoid tip, a type 2 fracture through the base of the dens, and a type 3 fracture through the body on the far right. So the management of these fractures differs depending on the site of the fracture. So a type 1, I'll just go back there, can be managed in an orthosis or a brace. Type 2 is usually in the young patient managed with a halo, but if you have a patient who's going to be particularly non-compliant, smoking, high risk of non-union, consider surgery. Type 2, going back there, type 2 in the middle, in the elderly, we're trying to manage non-surgically, and type 3, again, using a brace, so that oblique fracture through the body there. Next is a hangman's fracture, which when I initially started reading about it, thought would have had a very high incidence of neurological deficit, but actually it doesn't, despite the name. So it's bilateral pedicle fractures of C2. It's the second most common fracture of C2 or the axis, most commonly sustained in motor vehicle accidents due to a hyperextension mechanism, with the brakes or hitting something and sustaining a pars fracture, and then the secondary flexion injury on the way back with a posterior longitudinal ligament tear. So the classification system for this fracture is the Levine-Irving classification. Type 1's a vertical pars fracture with less than 3 mils of displacement. In this setting, you can manage this with a collar. Type 2 is a vertical pars fracture with greater than 3 mils, and this is managed in extension with a halo if it's less than 5 mils of displacement, or surgically if it's more than 5 mils. A type 2A is an oblique version of this fracture and can be managed with a halo, and type 3 is a bilateral facet dislocation with a pars fracture, and that's a very significant injury that requires surgical fixation. Now, this is clearly, obviously, rare and very fatal. In most cases, the Occipito-Atlantal dislocation, it's most common in young people due to ligamentous laxity. The reason I included it was during my reading was the interesting study I found in a JALS article that reported 17 cases of patients who'd survived this in the US in an institution. and that only 2 of the patients were noted to have the dislocation of the spine from the head at the time of the injury in the ED on the lateral X-ray. And there was a delay to diagnosis of this injury of an average of 2 days, with patients on the ward still having pain and requiring CT and MRI scans. If you survive this injury, you tend to go to the operating theatre, and the reduction manoeuvres actually sandbags under the thoracic spine and allowing gravity to reduce this injury, and then checking with the II and placing a halo. But interesting that a head dislocation is commonly missed if they make it to hospital on C-spine imaging. So subaxial trauma, multiple classification systems. The most commonly referred to is probably the mechanism-based system of Allen and Ferguson from 1982. As always, there's an AO classification, and the more practical classification that you may see used is this SLIC classification in day-to-day practice, which is a subaxial cervical spine injury classification. I think it's important to touch on the Allen and Ferguson, mostly just to talk about mechanism, and it's based on static X-rays. So we can have flexion compression, vertical compression, flexion distraction, extension compression, extension distraction, and lateral flexion. Just helps to describe the types of fracture injury you're going to have via mechanism of injury, and that's going back to that history and taking a quality history as a resident registrar in the emergency department. So SLIC is a newer system used, and it helps because it provides a scoring system which aids guiding in management, whether this patient can be managed operatively or non-operatively. It takes into account morphology, disc and ligament injury, and also the neurological status of the patient. So the morphology of the fracture or the injury, so no abnormality, compression or burst, distraction injury, or rotation translation significantly increases your score. Moving on to the next part of SLIC, which is the disco-ligamentous complex. If it's intact, 0, intermediate changes, 1, or completely disrupted with widening of the disc is a 2. And the third part of the classification system is the neurological status of the patient, which is clearly very important. And you can see the scoring system here. So intact, 0, root injury, 1, complete cord injury, 2, incomplete cord injury, implying time to intervention, providing better neurological outcome, is 3, and continuous cord compression. So this is the interpretation here. If you score under 4, you managed non-operatively. 4 is the grey area of operative versus non-operative. And if you score over 5, I'm looking down the path of operative treatment. So the subaxial injuries we'll move on to. So the unilateral facet dislocation, bilateral facet dislocation, burst fracture, teardrop, and wedge fractures. So unilateral facet dislocations usually involve, as you can see in the X-ray here, C5, C6, or C6, C7. It's a flexion, distraction, and rotation around the other intact facet, like a pivoting type injury. For it to be a unilateral facet dislocation, we'll normally have 25 to 50% of subluxation on this lateral X-ray. And reading through some of the literature, they describe this hamburger sign on CT, which someone's nicely pointed out. And the hamburger sign shows the tip of the inferior articular process is seen anterior to the superior articular process of the vertebral process below. And so that's that one facet translating, as you can see there on the X-ray. So the management principles in this case are to exclude a herniated disc and then reduce and fuse the injury. So this is the treatment algorithm, probably the best one I've found through reading. If there's no neurology, some people would argue this, but the consensus seemed to be that you would still do an MRI scan to assess for disc herniation. And if that's the case, if there's no herniation, you'd undertake a wake traction, like a tongue traction if you've got a compliant patient, so that they can communicate any neurological changes as you add traction, and then definitively placing them in a halo or a brace. The reason you want to check for hernial dislocation or translation is that if there is this injury present, with the reduction, you can actually cause the disc to prolapse back and cause cord compression. If there's stable neurology, again, undertaking an MRI scan to assess for a herniated disc and trying to undertake a wake tong traction. Otherwise, you'd be going to the operating theatre for open reduction and fusion in theatre, and you can address the disc at that stage. With progressive neurology, MRI scan again, and then looking for operative intervention. And a herniated disc, you'd be looking at an anterior approach like an ACDF to get good access to the herniated disc itself. Bilateral facet dislocations. So moving on from that 25 to 50% of subluxation is now over 50% of subluxation on the lateral C-spine X-ray. Approximately 40% of cases are associated with a herniated disc, and that's why it's important to have the MRI scan. Otherwise, you can drag that disc and compress the cord with your traction. It's often an unstable injury with an injury to the posterior ligaments, and it's managed with the same sort of algorithm as with the unilateral facet dislocation. Burst fractures, which we sometimes see lower in the L and T spines, are asked for opinions, but it can also occur in the C spine. I thought I'd include an X-ray with a large arrow, which I know is one of Mr. Harris's favourite things that the radiologists do, to point out the fractures when we can't quite pick them up. So they're associated with vertical compression. C5, C6 is the most common, like I said. CT can help to assess for retropulsion or any canal compromise, along with MRI, which can help with that posterior instability, or looking at posterior instability in the ligamentous complexes. Non-operative management in a collar for 6 weeks if there's no neurology and less than 50% loss of height, and on that MRI CT that you're happy that the posterior column's intact and supplying some stability to the injury. If indeed there's instability or neurology, you would consider operative management with closed reduction, or more commonly in the modern setting, an anterior corpectomy, discectomy and fusion. Wedge fractures, so injury to the anterior column, flexion compression injury, and again sort of C4, 5, 6 is most common. It's usually stable, but it's important to differentiate these from the burst fracture there we were talking about, because if you miss the posterior instability and manage it conservatively, can have detrimental outcomes. Normally you would undertake a CT scan to assess if there's less than 50% or greater than 50% loss of height, which helps to differentiate wedge and burst fractures. Teardrop fracture is an important one to pick up because it involves a 3-column injury. So it's a hyperflexion injury, and it's associated with high rates of spinal cord injury. They normally characterised here in the CT by an anterior inferior body fragment that stays attached to the anterior longitudinal ligament. It's also associated with posterior superior retropulsion of fragments into the canal. It's very important these patients get an MRI scan to assess for ligamentous instability and to assess the cord as well. And more broadly, just looking at management, this was quite a large topic again, so I didn't want to go into too much depth, or Deepan wouldn't get to his eyesores. So the subaxial management of non-operatively is collar immobilization or an external halo. Operative management is an anterior decompression corpectomy, plus minus grafting and fusion, or a posterior approach with decompression and fusion. Now, I haven't seen either of these operations done, but looking through some of the literature, the benefits of the anterior approach seem to be a simple supine positioning. You get good access to the disc anteriorly, and there's less muscle trauma. And they talk about the posterior benefits being you get better 3D control of the neck in the Mayfield table, and you get fixation, which allows manipulation with that. The facet can be drilled out, and it's easier from reading to approach the C-spine, the lower sort of CT spine junction, from the posterior approach rather than the anterior approach. So this is an anterior fusion just for any of the residents who haven't seen much spine work done. And then just to finish, just a word of warning that kept coming up through my reading was particularly for the registrars when you're seeing patients with neck pain, if they have a history of diffuse idiopathic skeletal hyperostosis or ankylosing spondylitis, even if there's no X-ray on, if there's no pain, no fracture on X-ray, it's important to have a high index of suspicion because they basically have a long lever arm and it's very common to have fractures. So have a low threshold for moving on to a CT or MRI for these patients. Thank you.